This is the Emergency Medical Minute, sponsored by Mile High Ambulance.
Hey guys, Dr. Lynch here, one of the ER docs at Swedish. Today I want to talk about SVT, or Supraventricular Tachycardia, and the two ways to treat it. So let's start off with what is SVT. So SVT is a broad term that encompasses all tachydysrhythmias that are generated supra, meaning above, ventricular, the ventricles. So anything coming above the point proximal to the bundle of His. In fact, the term SVT technically encompasses AVNRT, AVRT, atrial tachycardia, atrial fibrillation, atrial flutter, and multifocal atrial tachycardia. The one that we normally focus on is AVNRT. This is the most commonest cause of palpitations in patients with hearts that are exhibiting no true structural abnormality. So AVNRT, usually it's paroxysmal, can occur spontaneously in patients or upon provocation with exertion, coffee, tea, alcohol, thyroid disorder. Much more common in women than men. About 75% of cases are women. And it can occur in nice, young, healthy patients, as well as those who actually have chronic heart disease. So when you look at the EKG, usually the rate's in the 160 to 240 range, unlike sinus tachycardia that doesn't really get above 160. And you always have a narrow complex with a normal QRS physiology. So how do we treat it? Today, we're talking about specifically stable SVT. The unstable patients, they get a synchronized cardioversion at 0.5 to 1 joules per kilogram. So in order to truly treat the SVT, we need to disrupt the cycles of refractory pathways that actually result in the reentry circuit within the AV node. So really, we want agents that target the AV node specifically. Before jumping to pharmaceuticals, we've always been taught about the Valsalva maneuver. So this is kind of bearing down, acting like you don't have a bowel movement. So what this does is it increases your vagal tone, which slows conduction through the AV node and then prolongs the AV nodal refractory period, resulting in a normalization of that conduction. So more recently, there was this study that was called the REVERT trial that was published in The Lancet in 2015, where they talked about a modified Valsalva. So basically what they did here is they put the patients at a 30-degree angle, and then they have them blow into a 10 cc syringe for 15 seconds, and then they lay them flat, and they raise their legs to 45 degrees for 15 seconds, and then they sit the patient fully upright for 15 seconds. And when you compare the two, they found that the traditional Valsalva worked in about 17% of patients, and this modified Valsalva worked in 43% of patients with zero adverse events. So it's a free shot that you might as well try. So when this doesn't work, that's when you use pharmaceuticals. I think we're all pretty familiar with adenosine, and that's not really what I want to talk about today. The reason being is that, when you interview patients who have had adenosine, they often describe it as the worst thing they've ever experienced, and they would do anything to avoid this medication. So recently there's been a push to use non-dihydropyridine calcium channel blockers, such as verapamil or diltiazem, instead of adenosine. It's actually kind of ironic because up till 1989, before the advent of adenosine, we actually used to use calcium channel blockers. So we're coming full circle here. So in 2009, there was a randomized controlled trial where they investigated the slow infusion of calcium channel blockers compared to adenosine bolus. And there were significantly higher conversion rates in the calcium channel blockers, upwards of 98%, compared to the adenosine group at about 86.5%. So the adverse effects of calcium channel blockers usually are hypotension, and you can mitigate this by doing a nice slow infusion versus a quick IV push. What's the dose? For diltiazem specifically, that's the one that I like to use. It's 0.25 milligrams per kilogram over 2 minutes. And then you can repeat at a dose of 0.35 milligrams per kilogram in about 15 minutes. Or if that doesn't work, then you can do a slow infusion at 2.5 mg per minute up to a conversion, or up to 50 milligrams total, whichever you reach first. And usually the time to onset of diltiazem is about 3 to 6 minutes. So in summary, Remember SVT, narrow complex tachycardia rate of 160 to 240 in an adult. If they're unstable, synchronized cardioversion at 0.5 to 1 joules per kilogram. And if they're stable, always try the modified Valsalva. It says 43% efficacy compared to the traditional Valsalva at 17%. And then consider using calcium channel blockers like diltiazem over adenosine. It's much more tolerable for patients. And just remember, if you're going to do it, do a slow IV push over about 2 minutes. And the most common adverse effect of calcium channel blockers is hypotension with an average drop in systolic blood pressure of about 7 millimeters of mercury. That's all. Have a great day, guys. Bye.
We'd like to thank our sponsor, Health One Continental Division, and Swedish Medical Center for their financial contributions to the EMM. Donations from them and listeners like you make it possible for us to fulfill our mission of producing and spreading free medical education to the masses. If you enjoy our show, please consider making a one-time or recurring donation to help cover our operational costs and keep the EMM awesome. Click on the link in our show notes to make a donation. Thank you for listening.